Good morning, everybody. My name is Annika Reinten-Blaser. I'm currently working in Lucerne, Switzerland, and we will start with a session on ventilator-associated pneumonia. There should be also a co-chair. I hope that he will join us during the session. It's Michael Mansour from Boston, US. And as we are a bit late to start, it's my great pleasure to invite the first speaker, who is the ultimate expert probably in this issue, Jean-François Timsit from France, please. And he will tell us about is ventilator-associated pneumonia still an issue?
Thank you very much, Anita. I'm not sure to be an expert on it, but I appreciate the compliment. We will start with a provocative question. Is it still an issue? Yes, of course it is. It is. Here are my conflict of interest, not really directed on this particular talk. As you know, of course, there is a lot of hospital-acquired pneumonia, and indeed, ventilator-associated pneumonia represent a very important part of the problem. It represents about 20 to 42% deaths associated with deaths. The incidence is more than 15 per 1,000 MV days. And it is much more important that non-ventilated ICU HAP, and probably 50-50 with looking at the incidence, the overall incidence when we consider the whole hospital-acquired pneumonia. So, of course, it is still an issue. It is associated with organ failure. We all know that it is associated with septic shock in about 50% of the cases. With ARDS, more than 10% of the VAP is responsible for it. Multiple organ failure is also described in about 10% of the cases. It is the top one, ICU-acquired infection. In incidence, 15%, and incidence density, as I told you before. The main risk factors are duration of mechanical ventilation, of course. It is especially the case, and there is particular circumstances that increase the risk. ARDS, and mainly SARS-CoV-2, for example, COPD, other respiratory disease, major surgery, polytrauma, coma, of course, is the main risk factors. Immunosuppression, SARS-CoV-2 against, and intra-hospital transport are very important risk factors for VAP. If we look to the decrease using the prevention, we have a slight decrease in the number, in the rate of ventilator-associated pneumonia. Here in France, in a large network, or more than 50% of the ICU beds in France. But you see that this decrease is more pronounced for the youngest patients and not really important for the oldest one. And we, at this time, don't know perfectly what are the prevention measures that are functioning and that are not dangerous. If we look at the bugs, of course, Staph aureus and Pseudomonas aeruginosa are very important. Here a picture, 20-year picture worldwide. And Pseudomonas aeruginosa, Staph aureus represent half of the cases. But you see that in some continents, especially Asia Pacific and Latin America, you have about 25% of the cases that are due to Enterobacterales and non-fermentative bacteria. And it is due to, most of the time, to CAPIC or to carbapenem producer Enterobacterales and carbapenem-resistant Acinetobacter baumannii. And if we look to the resistant pattern and the species pattern, it is very different from one continent to another. About 60% of the cases in the US are due to gram-negative, and it is quite stable. But 70 to 80% of the cases are due to gram-negative in Europe. So a very different pattern, and the difference are very interesting to look at. The number of meropenem non-susceptible, methicillin-resistant Staph aureus, third-generation resistant coli, carbapenem non-susceptible Klebsiella increase very importantly. Especially it is the case for ESBL producers, of course, but I'm sorry. But also it is, but it is also the case for carbapenem producers, and mainly the case for Acinetobacter baumannii, with a very large increase in the carbapenem non-susceptible Acinetobacter baumannii, whereas Pseudomonas aeruginosa, resistant Pseudomonas aeruginosa and MRSA remain quite stable. If we look to attributable mortality, it depends on many things. It is very difficult to look at this point. It is depending on the intermediate severity of patients, and patients with intermediate severity have probably the highest attributable mortality. It also depends on the number of organ failure when VIP occurs, of course. Factors associated with the high relative risk of death is surgical ICU, aging patients, intermediate severity on admission, the presence at VIP onset on septic shock and multiple organ failure, and the presence of bacteremia. Interestingly, the impact of appropriate, adequate therapy, that is to say, effective in vitro during the first 24 hours of the diagnosis, is not so important. If we look to multi-state model, here it's an application of the illness-death model. When we look to the proportion to be extubated and discharged, and we introduce the adequation of antibiotic therapy for Pseudomonas aeruginosa ventilator-associated pneumonia, you see here that we were unable to demonstrate any impact of the adequacy of antibiotic therapy on the proportion of patients extubated and discharged alive, which is quite worrisome, and we wonder why it is the case. Perhaps it is due to inaccurate definition of VAP that may lead to over-treatment with no effect or even harmful effect of broad-spectrum antimicrobials. Perhaps it is due to late diagnosis, leading to late treatment unable to reverse the harmful consequences of VAP. Perhaps it is due to definition of adequate therapy solely based on the antibiotic susceptibility profile that is probably not sufficient, and we should have a look on pharmacodynamic properties of the antimicrobial. So to go in line with this question, we will have a look to a few questions. First of all, what we are talking about. What is the suspicion of ventilator-associated pneumonia? When to perform bacteriological sample? What are the best bacteriological exams? What are the potential benefits of molecular methods? And what is the best therapy? A lot of questions, but no definite answer for all these questions. Who are the patients that are clinically suspect of VAP? At this time, we really don't know. We pick up more than 35 international experts worldwide, and we ask for what are the main clinical and biological points you take into account to define suspicion of ventilator-associated pneumonia, with a scale from 0 to 5, using a Delphi process, of course. And what we found is the first one is worsening of gas exchange. The second one is hypotension and vasopressor use. And the third one only is fever, hypothermia, and purulent tracheal secretion and leukocytosis, which represent the main traditional clinical way of suspecting the disease. So we are not able to define precisely the suspicion of ventilator-associated pneumonia. And it is clearly an issue. And perhaps it depends on population. Perhaps for non-invasive ventilation, it is very different. For tracheostomized patients, it is also very different. When you have pre-existing pulmonary disease, probably new infiltrate is impossible to define. In ECMO patients, the worsening of oxygenation is not possible to define too. In immunocompromised host, probably the radiological picture is very difficult to obtain. So probably clinical criteria alone is preferable to any scores to try to define this suspicion of ventilator-associated pneumonia, but we don't know at this time if we are performing early, late, or at a good time microbiological exams. And there is an issue, which is the definition of ventilator-associated tracheobronchitis and ventilator-associated pneumonia. Probably there is two different sort of ventilator-associated tracheobronchitis. Probably one is an early ventilator-associated pneumonia, and another one is ventilator-associated tracheobronchitis not requiring antibiotic therapy. That is the opinion of the European guidelines, not to use antimicrobial in this case. So we need, as you know, radiological chest X-ray is not susceptible to improve our way of defining the disease. We need new morphological tests. Probably mobile CT scan will be good, or ultrasound examination, and daily ultrasound examination to detect new infiltrate, which is very, very difficult in the routine at the bedside. We should perform bacteriological exams, and all the recommendations agree on it. It is clear that we need to perform, before any new antimicrobial therapy, we need to perform bacteriological exams. But which one? It is really an issue. If we look to, for example, the US and the European recommendation, one is pro-non-invasive, the other one is pro-distal quantitative. So, weak recommendation for both guidelines, and we don't know at this time what is the best and the preferable way of performing the bacteriological exams in this kind of suspicion. Probably, and we need to have in mind that we need to sample all the patients suspected of that, sample patients before any change of antimicrobial, because if we are not doing this, we are at risk of over-treated patients with negative samples, and we have a very important risk of masking other disease, mimicking pneumonia. We have to start treatment before culture results, and sample quantitatively, it is my opinion, trying to spare antimicrobial and to stop early the antimicrobial. What is the place of MPCR is really, really an issue at this time. What do we know? It is biologically accurate. Some microorganisms are not targeted by syndromic MPCR, and it is clearly a problem. What are the open issues? What are the impact of viruses? And when we use MPCR and we discover that there is a lot of co-infection, not only with rhinovirus, but also with the RSV or metapneumovirus. So probably there is a role, and for HAP, we demonstrate that there is an increase in the risk of death when there is a co-infection with viruses. The role of quantification of the RNA is not so simple at this time. The impact of previous antibiotic therapy on MPCR result is also an issue, and the evolution of MPCR with therapy have not been explored at this time. What we know is that the spectrum of most of the commonest MPCR is not full, and you have some hole in the spectrum, and they miss some targets which are probably important, Citrobacter friendly, Morganella morganii here, Stenotrophomonas maltophilia for this first one, and we miss some resistance mechanisms with the other. So the interpretation is very difficult, and we need to move and to change our education process in order to better use this kind of results that are available in my unit very early, and after 2 hours I have all this information for all the patients. If we look at the result of the impact of this kind of technique in improving the way we are treating patients, this kind of MPCR is able to modify the antibiotic therapy in 80% of the case, with the escalation in 50% of the case, and escalation in 24% of the case. It is for Filmare here, and with Univero, we also perform the same simulated models using experts. The median turnaround time was only 4.6 hours, and we identify 90 out of the 11 and 12 bacteria that has been recovered. And sensitivity was better for gram-negative bacteria and lower for gram-positive cocci. And if we look to the impact, it is able to change the antibiotic therapy in 2/3 of the cases, with earlier initiation of effective antibiotic in 21% of the cases, early de-escalation in 37 patients, 39% of the cases, but one lead to a shift to ineffective therapy due to other resistant mechanisms in some cases. So we have to learn how to use it, and we need randomized controlled trial in order to demonstrate that it's safe antimicrobial and that it saves patients, and I'm not sure at this time. Other unresolved issue, and I will finish with it, about therapy. Should we treat patients under the bacteriological threshold? Probably yes, using BAL. We recommend monotherapy if it is active, no nebulized antimicrobial based on the randomized control trial, and short duration of therapy based also on randomized control trial. But there is a lot of issue about the fact to break the laws. What are the cases when we have to prolong the antibiotic therapy, when we have to perform dual antibiotic therapy, when we have to add nebulized antimicrobials? And it is also a lot of issues that remain at this time. Thank you.
Thank you very much. We got a few time for questions from the audience. While you are thinking of one or two questions, I maybe start and ask who is in the audience, who is using multiplex PCR in your daily practice? Quite some, yes, thank you. And then I got the question for you, do you use surveillance cultures?
Yeah, a little bit. We perform some study about it. First of all, surveillance culture have an improper positive predictive value. And it leads to overuse of broad-spectrum antimicrobial in simply colonized patients in about 50% of the cases. What we found is that there was a lot of difference if we look at oropharyngeal secretion, colonization, and stool colonization. And if we look to oropharynx, it is by far better in terms of positive predictive value. And secondly, if you look to semi-quantitative methods, we also demonstrate that the increase in the number, the rate of resistant organisms in the stools is directly associated with the probability of having a resistant ESBL in this case, a resistant ESBL VAP for patients. So we use it, but you should know that the positive predictive value is not 100% at all.
Thank you very much. No questions from the audience, then thank you once again.
Thank you.
And it's my pleasure to invite the next speaker, who is another expert, Giuseppe Citerio, and he will tell about ventilator-associated pneumonia in neurocritical ill patients.
Thank you very much for the kind introduction. I'm not an expert or VAP, but I deal with neurological patients, and sometimes we are focused on treating the brain to try to save the most we can of the damage of the patient, and we face the problem of having a VIP also in our unit. And I don't have conflict of interest for this presentation, and I will review with you the evidence we have till now, and I will present to you the data coming from a very large collaborative study called Center TBI, in which also we explored the incidence and the risk factor of VIP in neurological patients. If you think we are talking about generally in these two slides about stroke, but then we will go dealing with DPTBI. If you think about patients with a neurological damage, and we are talking about stroke patients, they are not so severe compared to trauma. But if you look at the problem we face with neurological patients, frequently it is dysphagia. So the patient is not able to have a good coordination, different study, different tools for studying dysphagia, but dysphagia is quite frequent. And if we think about the association of early pneumonia, not association with ventilation, we are talking generally speaking now, and dysphagia, we saw that in neurological patients, even before the intubation, there is a risk of inhalation, and so there is a predisposition of having pneumonia or some bacteria in the respiratory tract. If we go to ventilator-associated pneumonia in TBI, and most of the presentation will be focused on traumatic brain injury. As you can see in this recent meta-analysis, we have studied in which the number of patients is not so huge. We are talking of the largest one is 300 patients, in which we see that there is a mix of pathology, mainly TBI. Most of them are severe. So we are talking a patient with a Glasgow Coma score below 8. And what has been done is to understand which is the incidence of VIP. And we face some problem that already Jean-François touched before. The first problem we have is the definition of the criteria. Also in this setting about pneumonia, not all the study did apply the same criteria. And looking at the incidence is around 30%. The mean value is 36 in this case series. So we are talking about a problem that a third of the patient will experience during their ICU stay. Think about all the severe cases are all mechanically ventilated and intubated. And if we focus on TBI, they are usually intubated more than 1 week if they are severe. And then we will discuss, not in this presentation about the tracheostomy, but most of them remaining in the unit more than 1 week will receive a tracheostomy. And looking at the study summarizing this meta-analysis, most of them are retrospective, not many of them are prospective. And I think, importantly, if we have to define this, the incidence is around a third of a patient, and both study, prospective and retrospective study, have similar result, even if the prospective study, well done for searching for pneumonia with a standardized protocol, are having a little bit higher incidence of VIP. And, okay, I'm sorry. Severe and not severe TBI, we're talking of patients intubated and ventilated. Not severe TBI at admission are a small part of it. Severe and all the patients have the same incidence, and also there are no difference, no, there is a difference, sorry, about the timing of the VAP. If we move from within 3 days or 4 days or longer than 5 days, as you can see, the maximum incidence is around 5 days. And we will see also in instant TBI what are we talking about. And I think looking at the risk factors specific for this population, because age is a common risk factor, smoking, and so on, we will see that some of the factors are associated with the coming VIP. So tracheostomy is a late maneuver, but also in the early phase, barbiturate infusion is a characteristic risk factor. So deep sedation is a characteristic risk factor for VIP. And also the severity of the trauma. See, as NIS, he had IgA3, and the presence of extracranial injury. And we are facing a problem, and sometimes we ask if this problem, VIP, does have an impact on mortality, length of stay in the unit. And as you can see from this meta-analysis, putting a VIP over the risk of a patient, so dividing patient having or not having VIP, doesn't change mortality in most of the study. And the problem we will have is that there is an increase in days of mechanical ventilation and a small increase in the ICU length of stay, because the ICU length of stay is mainly due to the severity of the pathology, but MVP increase length of stay a little bit. What we did, we selected from the Center TBI data set, Center TBI prospective data collection on traumatic brain injury in Europe, 66 centers, has been founded by the EU, by a large amount of money. We were focused mainly on TBI, traumatic brain injury, so we studied genetics, biomarkers, CT scan characteristics, but also we explore all the treatment of the severe patient inside the ICU. And we have a cohort of about 2,100 patients in the ICU. We selected in this cohort patient that has been ventilated for more than 48 hours. and that they had a length of stay longer than 72 hours because we wanted to have enough time for studying the problem. And so we removed a patient that died earlier and then went away from the unit in a couple of days. And the definition, and I think reflect what Jean-Francois said, was based on radiological and, evidence of pulmonary infiltration plus symptoms like fever, leukocytosis, purulent secretion, and hypoxia during mechanical ventilation lasting more than 48 hours. And the numbers coming from this large data set, that is the largest study on TBI, is the incidence is around 20%. And I return back later on to this slide, and I want to present you the transition over time. As you can see in blue, you see the incidence of VIP, and you can see there is a rise in the first day with a peak on day 5, 7, and then the incidence goes down. There are the blue line, this line, a little bit darker, is the mortality after VIP. This light, very light blue is the part of patient that left the unit after having a VIP. So as you can see from this chart, we have a median day of 5, the interquartile range is 3 to 7, and we define the patient who develop VIP. So patients who are younger, usually they have a high-speed accidents with other lesions, high incidence of abuse of alcohol and drugs, thoracic trauma was associated, and they had more respiratory failure during the ICU stay. Curiously, we explore 66 centers across Europe, and we have a possibility to make some comparative effectiveness research. So we compare centers. And so for all the analysis we do, even in the treatment of TBI, we are talking here about VIP, we were searching if there were some center and national difference. And as you can see, there is a huge difference between centers in the percentage of VIP. This for us have to meditation we did after seeing this result. Probably the treatment is different, and we will see something in a short time. And probably there is a problem of diagnosis across the center, probably, and the uniformity of diagnosis is not uniformly accepted as we said. Looking at the PO2 or the PO2 ratio, we did this test only for checking if the day in which VIP was diagnosed was associated with a reduction of oxygenation, and we found a reduction in the days before VIP definition, identification, and with a not so, if you look at PF ratio, not so low numbers in the whole population. We were worried if VIP did have an impact also on CO2, because we managed closely the CO2 because of a problem of intracranial hypertension, intracranial volume, and we didn't see this effect on the PCO2, so PCO2 diffuse more easily, and we don't have any effect on PCO2 in this population. And we started to think about the risk factor that could justify the difference between the countries. We saw countries in which all the patients were exposed to antibiotic prophylaxis. Some countries didn't expose any patient to antibiotic prophylaxis. We have different use of H2 antagonists and different use of barbiturate. All these are associated with a different incidence of VIP in traumatic brain injury. So the prophylaxis, antibiotic prophylaxis was associated with a reduction, as you can see, 0.69, and the confidence interval is below 1. H2 antagonists double the risk of having VIP during the ICU stay, and deep sedation that we could identify with barbiturate is associated with an increased risk. But for example, hypothermia wasn't associated, wasn't used so often, but wasn't associated with an increased risk. We found the same finding of a meta-analysis. Patient with VIP had a longer duration of mechanical ventilation, and almost the double compared to the patient without VIP, and the longer ICU stay, 6 days longer, 10 days longer probably, 7 days longer compared to the patient without VIP. So we have a more long length of stay. And we could say that also in this large series, there is no association with mortality or worse outcome. The outcome was mainly driven by the severity of the brain trauma, not by the incidence or not the incidence of VIP. And the overall mortality of the population at 6 months is 22. So I think we did explore, let's say, an additional problem, a secondary insult during the ICU stay in traumatic brain injury, said VIP, and we can say that one patient every 5 will experience the problem. I think the most important concept we found in our research that some therapy we are applying could have an influence on VIP. So probably we have to make other study in which we can test avoiding some strategy for having the certainty that avoiding some strategy, we can reduce the incidence of VIP because we want to reduce the length of stay linked to VIP and the length of mechanical ventilation. On the other side, we are happy to see and to confirm that no impact on long-term outcome we have seen in this population. Thank you very much for your attention.
Thank you very much. Questions from the audience? If not, then I have a question. You said that prophylactic antibiotics were shown to be predictive. Do you ever use prophylactic antibiotics, for example, in traumatic brain injury combined with chest trauma or whatever patient group?
The problem of prophylaxis is more complex. Many centers do use prophylaxis if they insert an ICP catheter. So they are using, generally speaking, cephalosporin. So the patient have a prophylaxis for another reason, mainly. So we have a large population, and we saw the patient exposed and not exposed to antibiotic. The reason for the exposure wasn't the risk of VIP in the most of the cases. So the patient were exposed to the antibiotic, and the antibiotic prophylaxis was associated with a reduction of the risk. But the antibiotic wasn't done for that reason.
Okay, thank you very much. Relieved with this answer. And one more quick question. Timing of tracheotomy, is it important in this setting?
It is not the topic because we didn't find an association on timing and the VIP incidence. But as you can imagine, the more severe patient goes to tracheostomy. We did a study on tracheostomy. There are differences between the centers, more huge than the difference in the therapy applied, because there are centers doing tracheostomy very early in the first 3 days. So they made the tracheostomy before VIP could happen, and some centers do it very late. So it's difficult to understand because there is a bias in selection of a patient, and we didn't see any benefit in having a late tracheostomy, and we define early and late in 7 days, and probably the patient in the analysis we did, that did the tracheostomy around day 7, 10, the association with a less long ICU stay, but not with mortality, was present. So I cannot say that having an early tracheostomy will prevent in this set. I cannot say now it could prevent VIP, because we usually have a mean time around 7-9 days of tracheostomy.
Thank you very much.
Thank you.
And now I hand over to my co-chair. Welcome.
Okay, thank you so much. Oh, is this on? Great. So it's a pleasure to welcome Dr. Niederman to the stage, who will give us a talk on the future of aerosolized antibiotics. Thank you so much.
Well, thank you. It's a pleasure to be here and to talk about this topic. I guess my question is really not what is the future, but is there a future? And I think some of the recent negative trials have really raised a question about whether or not we will see more trials of aerosolized antibiotics. So I've listed my disclosures here. And there are many challenges, obviously, that we've heard about today in the treatment of ICU pneumonia. We have increasingly resistant gram-negative pathogens. We do have some new antibiotics that we're going to hear about for MDR gram-negatives. but they've been tested to show equivalence, and that's not necessarily a clear advantage. We need to avoid the overuse of systemic antibiotics, particularly with using fewer drugs, shorter durations of therapy to avoid toxicity and selection of resistance, and potentially there may be a role for aerosolized antibiotics to achieve that endpoint. Adjunctive inhaled antibiotics are a way to get some of these endpoints, but to get maximal benefits, we really have to optimize the delivery of the aerosol, and we have to use new technologies. There are newer aerosol delivery devices, not your father's nebulizer. And we have new data that shows the value of adjunctive aerosolized antibiotics in VAP, but those data come with more innovative trial designs and novel endpoints. And I think that this is a key factor in trying to show the importance of aerosolized antibiotics. I've published a review a couple of years ago about the place of aerosolized antibiotics as adjunctive therapy for ventilator-associated pneumonia, and it included a number of the recent trials. But the first point to emphasize is that there are multiple delivery devices of aerosols. There's jet nebulizers and some of the older technologies, but the newer technologies involve the vibrating mesh nebulizers, and I think that some of the current trials that have been done that show some benefit have used the vibrating mesh nebulizer, but there's still discussion as to whether or not we are optimizing the use of these devices. One thing that's very clear is that most ICUs have no idea how to use nebulizers and how to deliver aerosolized antibiotics. This was an online survey of the use of aerosolized antibiotics in 182 ICUs in Europe. And first of all, aerosol therapy with antibiotics was used in only 87 of the 182 ICUs, and less than half of them used it more than 3 times a year. Many healthcare workers never use aerosol therapy. They like the jet nebulizers the most, and most of them don't really understand how to use the methodology efficiently, and some people had no idea what type of nebulized system they're actually using in their ICUs. So there's clearly not a lot of attention in many ICUs to how you're delivering the aerosol. So how do you optimize aerosol delivery? This too is a controversial issue, and Dr. Ruby, who works with the European VAP network, is very, very particular in his studies of aerosol therapy as to how to deliver it. And the technique that he's used is a little bit different than we used in the inhale trial that I'll describe in a few minutes. And he, in fact, has been very critical of the inhale trial because we got negative results. And he said one of the reasons we got negative results is we didn't use his formula for the delivery of aerosol. I'm not sure if he's right, but certainly it's a discussion worth having. So he recommends using primarily a vibrating mesh technology rather than the jet and rather than the ultrasonic nebulizer. And vibrating mesh has been used in a synchronized or unsynchronized way. He prefers to use it in an unsynchronized way with continuous running so that it fills up the inspiratory tubing and creates a dead space. And he actually places it in the inspiratory tubing distal to the Y connector rather than closer to the patient because he feels that he'll get better delivery with that technology. He uses a dose equal to a typical IV dose and adds to that the calculated extrapulmonary deposition. And he has very, very strict criteria for what he does with the ventilator. He puts them in a control mode of ventilation. And so many of these patients need sedation during the delivery of the nebulizer. Tidal volume is 7 to 9 mils per kilo. Again, put in the inspiratory limb at a lower flow rate, a respiratory rate of 12, an IE ratio of 1 to 1. And again, it's important to remove the HME filter. So what he would argue is if you do a trial of aerosolized antibiotics and you don't adhere to every one of these principles and you get a negative result, that was a methodologic issue. Again, we used a totally different system in the inhale trial that I'll mention in a few moments. So did design issues lead to negative trial results? I think that's still a very important question. Now, This slide I don't expect you to read, but this summarizes the most recent trials, including the ISICEM study and the INHALE trial, which I'll discuss in more details. And generally, all of these trials used vibrating mesh technology with either a continuous methodology or with a synchronized process, which we used in the INHALE trial. So you could argue that maybe these trials had better delivery, but maybe not the optimal delivery according to Ruby's concepts. Early on, we were encouraged with the use of inhaled amikacin, which was used in the subsequent INHALE trial. We did a prospective randomized controlled trial of adjunctive aerosolized amikacin at 400 milligrams twice a day, 400 milligrams once a day, or placebo. We did it in a small group of patients with about 50% frequency of MDR pathogens. And what we identified is, looking at the use of antibiotics at the end of a week of therapy, we saw that the use of systemic antibiotics was markedly reduced in the patients who got the inhaled therapy twice a day, reduced but not quite as much in the people who got the inhaled antibiotics once a day, and not reduced nearly at all in those who did not receive aerosol antibiotics but aerosolized placebo. We also saw more de-escalation with the use of higher dose of inhaled amikacin. And so we were very excited that if we had an endpoint of counting the amount of systemic antibiotics after a week of therapy, we might be able to reduce that with the use of adjunctive inhaled antibiotics. There's also data that if you use inhaled antibiotics, you actually reduce the frequency of MDR pathogens. And these are data from a study at Stony Brook looking at VAP and VAT, showing that when patients got inhaled antibiotics, rather than inducing resistance, it minimized the resistance in the patients who received inhaled antibiotics. So very encouraging data with more novel kinds of endpoints for looking at the resolution of important findings with the use of aerosolized antibiotics. Unfortunately, when we do larger clinical trials, there are compromises that are made. And these larger trials, I want to focus on the ISICEM study and the INHALE study, were negative trials. And I think a lot of this is related to methodology that was imposed by the nature of a large trial. So this was a randomized controlled trial of inhaled phosphomycin amikacin for patients with ventilator-associated pneumonia. And they received, again, continuous treatment with aerosolized nebulizer, and there was no difference in mortality. Their primary endpoint was a novel one, which is the change in the clinical pulmonary infection score over time. And as you can see graphed here, there was no more rapid resolution in the individuals who got aerosolized antibiotics. They look at some secondary endpoints. So the aerosolized phosphomycin and inhaled solution had fewer positive tracheal cultures at day 3 and day 7. But one of the problems in this trial, and was one that we had in the inhaled study as well, is that they had many patients who got prolonged antibiotic therapy before they were ever enrolled and before they got the aerosolized therapy. So the mean was 6.6 days of prior antibiotics before aerosol therapy in this trial. In 32 patients from the US, so a small number, the duration of pre-antibiotic therapy prior to randomization was 3 days. And here there was actually a significant improvement in CPIS with the aerosol therapy. And again, for potentially drug-resistant pathogens, there was also a potential benefit of the aerosolized therapy. So again, you can see from this graphic here, less, again, isolation of resistant pathogens at day 3 and day 7 with the use of the aerosolized therapy. So there are some potentially positive signals, but diluted, I think, in many ways by the trial design in a large number of patients. We published the INHALE trial about a year ago. We looked at 700 patients who got 1 dose 700 patients who were enrolled in the study and got the aerosolized amikacin 400 milligrams twice a day versus placebo. They had to have radiographic pneumonia and elevated CPIS. And our primary endpoint was mortality at 28 days to 32 days. And there was no mortality difference in the primary endpoint analysis. Again, the problem here was that many of these patients had prolonged antibiotic therapy. along with the inhaled therapy. And although originally we had proposed that in the original design that patients in both arms get 7 days of systemic therapy and they get inhaled antibiotics along with systemic therapy, and the continuation of antibiotics beyond 7 days would be defined as a failure, most of the ICUs at that time were not choosing to do short duration therapy, and as a result, most of them used longer durations of therapy than was prescribed in the trial, and we couldn't use that endpoint, and we reverted to an endpoint of mortality, which was not significantly different in the groups. When we looked at some of the secondary endpoints, bronchospasm was a little bit more common with inhaled therapy. Pseudomonas eradication was more with the inhaled antibiotics, but there was no survival benefit. And again, as I pointed out, the mean duration of systemic therapy was 18 days in both groups, despite the fact that the protocol had actually asked for only 7 days. And I think that that ultimately made it impossible to see mortality differences, because in the placebo group, if they weren't getting better, they just continued the systemic therapy. We were really hoping to demonstrate, as we had in the earlier phase 2 study, that adjunctive aerosolized therapy could reduce systemic antibiotics, or at the least achieve the same outcome with use of less systemic antibiotics. And that clearly wasn't possible when this was made a larger multi-center study. So Ruby has been, of course, critical of our data. He didn't like the idea that a large study got done and that it did not show a positive result. And he felt that more patients with resistant pathogens need to be included in these trials. He even proposed the idea that we should be using monotherapy with inhaled antibiotics in highly resistant pathogens compared to systemic therapy. He did not like the synchronized process that we use for delivery and likes the continuous use of nebulization with the mesh nebulizer. And also, there's a debate about the dosing that we used in our study. He felt that we used much too low a dose. We chose that dose based on ELF concentrations from BAL, and he feels that a lot of these ELF concentrations are actually not accurate measurements of the alveolar levels of antibiotics, and so there's some debate about dosing. So I think that the current state, as recommended by guidelines, is unclear. In the IDSA, ATS nosocomial pneumonia guidelines, they say to add inhaled antibiotics to systemic antibiotics for gram-negative pneumonia when there's multi-drug resistant pathogens, sensitive only to drugs like polymyxin and aminoglycosides, but again, low quality of evidence for that statement. They recommend using adjunctive inhaled colistin for Acinetobacter, sensitive only to colistin, and the same for carbapenem-resistant organisms. But they acknowledge we need more studies for inhaled antibiotics, and they recommend that it could be used as a treatment of last resort for non-responding patients. So they were moderately supportive of continuing therapy, but again, I'm not sure that they are going to encourage clinical trials with those recommendations. In the European guidelines, which I was part of, we did not recommend the use of inhaled antibiotics, and the European Society of Clinical Microbiology and Infectious Disease also advised against their use due to the weak evidence. My view personally is that we should be using adjunctive therapy of inhaled antibiotics for MDR VAP, for systemic therapy that's penetrating poorly. So if you're relying on colistin or if you're relying on aminoglycosides, they're not going to work that well as systemic therapy, and you probably should do adjunctive inhaled therapy for that. Patients who have a poor early clinical response, you might want to add inhaled therapy to salvage them. And in VAT, I think it may be a way to avoid systemic therapy to use monotherapy if there's no pneumonia, no systemic toxicity, of using only monotherapy with an inhaled antibiotic. But should we be doing more trials in the future with inhaled antibiotics? In favor of saying yes is that the small studies are positive and they show benefit, more bacterial eradication, less systemic antibiotics, less MDR pathogens emerging during therapy. They can work alone probably for extensively drug-resistant pathogens and may work even better compared to systemic therapy for pan-drug-resistant pathogens. But there's some debate. Should this be a primary therapy rather than adjunctive therapy? It sounds pretty severe to recommend only inhaled antibiotics for a sick patient with a highly resistant pathogen pneumonia, but if we know the systemic drugs aren't getting there and aren't effective, maybe it's not such a severe recommendation. Against the idea of more trials is that there was no reduction of mortality in these larger trials and no improvement in the CPIS and improvement in resolution in large populations. But I think the key is going to be improved design, and I think if we're going to do more studies, we need better design than we've had in any of these large studies. We need novel endpoints. I like the idea of CPIS measured serially as a clinical resolution endpoint, using systemic antibiotics as the primary endpoint. If you could really design the trial well and use less systemic antibiotics with adjunctive therapy, even equivalence would be a win. Microbiologic eradication, antibiotic resistance as endpoints, much more so than mortality. We have to limit prior antibiotic therapy prior to aerosol therapy. That was really, I think, a sabotaging factor in some of these studies, as was clear from the ISICEM and the inhaled study. We want to define the optimal duration of inhaled therapy. Probably doesn't need to be more than 7 days or 10 days at the maximum. We want to optimize the delivery of the drug with therapeutic drug monitoring. But again, there's some, as I pointed out, methodologic issues in measuring epithelial lining fluid concentrations rather than true alveolar concentrations. We ideally want to enroll a population that has a high rate of potentially drug-resistant pathogens. 50% may not be high enough. We want to try to find a population that can benefit. So we don't want to enroll people at very low Apache scores who are going to get better no matter what you do, or very high Apache scores who are going to do terrible no matter what you do. And the sweet spot seems to be a score between 10 and 25. And again, I think a debatable point is whether or not we could design studies with aerosol alone as primary therapy versus systemic therapy, using the aerosol in high doses against potentially drug-resistant and extensively drug-resistant pathogens. So the answer, I think, is that there may be a future for inhaled antibiotics, but I think that we've participated in flawed trials, and we've got to design better trials to avoid some of the problems of the past. Thank you.
Because of time, we'll take perhaps just one question from the audience, if there is one. I have one very brief question. Dr. Niederman, do you think that we should be developing new antimicrobials that are actually PK optimized for the lung? And I think a lot of the bottlenecks and barriers you spoke out loud may be inherent to drugs that are being designed for systemic use. Should we?
Yeah, I think that would be fabulous. I mean, again, although interestingly, although that sounds appealing, and because of that concept, I was always sort of against the idea of trying to aerosolize quinolones, because I felt quinolones penetrated well, and yet, as you know, there have been a number of trials looking at aerosolized quinolones nonetheless, some showing benefits, some not so clear. So if you can optimize the delivery of aerosol, you may get such a high local concentration that even exceeds a PK-optimized delivery of a systemic antibiotic. So I don't know the answer, and I don't know if we could ever develop a PK-optimized antibiotic that could get a high enough concentration in the lung to deal with these extensively drug-resistant pathogens compared to what we might deliver with a high concentration of inhaled antibiotic that doesn't get absorbed.
Great. Thank you so very much.
Thank you.
Thank you. Our next speaker is Dr. Ferrer, who will be telling us about new treatment options for gram-negative infections. Thank you.
Thank you, Mr. Chairman. I'm going to discuss about new antibiotics. Those are my conflicts of interest. So many ICUs now are facing with this new challenge of difficult to treat resistant pathogens. As new antibiotics are developed, new mechanisms of resistance are appearing. So many of us are facing with this problem of difficult to treat pathogens. For many areas of the world are facing this trend. In this case, are carbapenem-resistant enterobacterales, but many other multi-drug resistant microorganisms are increasing around the world and in different areas of the world. And this is a big problem during this pandemic, where this viral infection by SARS-CoV-2 also increased the risk of VAP in comparison with other viral infections and also in comparison with other conditions. And in this COVID study, most of the microorganisms involved in these VAPs are gram-negative. Almost 83% of them are gram-negative, and in some cases, multi-drug resistance gram-negative. So this is a nowadays problem in many ICUs. This is the antibiotic consumption in my region. We had during the last 12 years a decrease, or at least in the last 2 years, a decrease in the consumption of meropenem, for example. But in the red triangle, you can see the consumption in 2020. So there is an increase above the trend in 2020, and much more DDDs per 100 discharges in the ICU than expected for 2020. The same for piptazo and also the same for colistin. So we have an increase in the use of these antibiotics for gram-negative infection. Another issue is that inappropriate antibiotic therapy, especially in VIP, is associated with higher mortality and also higher morbidity. In this case, discussed as additional days in the ICU related to this inappropriate therapy. So my statement is that we have resistant pathogens, which are the most important predictors of inappropriate antimicrobial therapy. That antimicrobial therapy is associated with higher mortality and morbidity, and the actions we have to take are, of course, antimicrobial stewardship, of course, improvement in the empirical therapy to try to avoid this inappropriate empirical antibiotic therapy, but also we need to discuss about which is the role of the new antimicrobial agents for gram-negative. Here you have a list of the new antibiotics. Some of them are not so new. You can see that these are good news because we have several of them, but they do not cover all the options we need. Especially we have some problems with metallo-beta-lactamases and still some problems with Acinetobacter, but we have, of course, some improvements. I'm going to review these new antibiotics using this pyramid of knowledge. In the base of the pyramid are the information coming from observational studies. So let's say real world evidence. I will start with this study, including patients treated, 38 patients treated with ceftazine-avibactam, that has been compared with 99 patients treated with colistin. As I said, this is observational. Patients have bloodstream infections or pneumonia. And the main finding of the study that there is a lower mortality in this observational study in the ceftazine-avibactam group. And in fact, not only a reduction in mortality, also the number of patients that were discharged home is higher in the group of patients treated with the new antibiotic in comparison with the old antibiotic, and this could be related also to the morbidity because the rate of AKI is higher in the colistin group as expected. Again, ceftazine-avibactam, in this case, the study is an observational study in Klebsiella pneumoniae bacteremia resistant to carbapenems. And here we have 4 groups of patients treated with ceftazine-avibactam and also patients treated with meropenem plus colistin, meropenem plus aminoglycosides, or other combination. And you can see in terms of clinical success, the clinical success is better with ceftazine-avibactam. So again, a message saying that the new antibiotics probably in this scenario are better than the old antibiotics we had in this moment. Again, real-world information from ceftazine-avibactam. In this case, are 200 patients coming from 6 medical centers in the US between 2015 and 2019. All patients received ceftazine-avibactam, and the message of this trial is when they analyze the patients that receive early treatment, that's, let's say, in the first 48 hours in comparison with patients which receive the treatment in the later phase, this is an independent factor that was protective for the main outcome of this study, which was clinical failure. So more clinical success when patients receive early treatment with ceftazine-avibactam. And in this case, I'm going to discuss ceftolozane-tazobactam. In this case, it's a study, again, observational study. The comparison was To patients that receive colistin or aminoglycosides, again observational, 200 patients from 6 US medical centers. Patients have multi-drug resistant Pseudomonas infections. Almost half of them were septic or in shock, and most of them are admitted in the ICU, so close to our patients. You can see here that the rate of clinical cure, the rate was higher for ceftolozane-tazobactam, mortality is similar, and the rate of AKI, again, is higher in the group of colistin. So the same message with ceftolozane-tazobactam, in this case, focus in infections by multi-drug resistant Pseudomonas. Same information coming from Italy. In this case, patients with ceftolozane-tazobactam were compared in a case control study with patients treated with colistin or aminoglycosides. And again, the message is the same rate of clinical cure and mortality by lower rate of complications with ceftolozane-tazobactam. Also, the same group of investigators analyzed the impact of delayed administration of ceftolozane-tazobactam, 226 patients in the US. In this case, early therapy was considered the first 5 days, late therapy was considered after 5 days, and again, early administration of new antibiotic, in this case, ceftolozane-tazobactam, was associated with lower mortality in this case. All patients have multi-drug resistant gram-negative infections. So higher evidence we can find in a randomized control trial. Of course, in this case, the design of the trial is very important. I want to mention this trial. This trial is a BAPA trial done mainly in Spain. And there are no new antibiotics here, but it's a BAP trial and include colistin, so I want to also stress this data from the Magic Bullet trial. Patients were randomized to meropenem or colistin with BAP. And the most common pathogens in this case were Acinetobacter, Pseudomonas, and Klebsiella. And 38% of the isolates were resistant to carbapenem. And you can see that again and again, despite the mortality clinical group was similar, the rate of needing renal replacement therapy is much more higher in the group of colistin. This is the pivotal clinical trial for imipenem-relebactam. In this case, it's a HAP and BAT trial. Patients were randomized to imipenem-relebactam or PIP-TAZO every 6 hours. It's a non-inferiority design, include both BAP and HAP, and the most frequent pathogens were Klebsiella and Pseudomonas. The result of the trial is non-inferiority for both study drugs. So maybe to have more information, we have to go to Restore IMI-1, in which in this case is a pathogen-focused study, and patients were randomized to IMI-relebactam or colistin imipenem in this study. And the infections included in the trial are UTI, intra-abdominal infections, nosocomial pneumonia, and all patients have imipenem non-susceptible infections. So as you can see in the table, the clinical response was better for imipenem-relebactam, and the mortality and the morbidity was lower for imipenem-relebactam. So again, in comparison with colistin in difficult to treat infections, new antibiotics, in this case imipenem-relebactam, was doing well in this clinical trial, and this was quite consistent in the different time points of the studies, sending a very consistent message, also a very consistent message for the acute kidney injury that took place in this trial, especially in the patients that receive colistin. Another new antibiotic that I haven't discussed is cefiderocol. I'm not going to discuss a lot about the mechanism of action, but just to remind you that this antibiotic entered to the cell using the iron channel, and this is quite innovative in comparison of the rest of the antibiotics I have discussed before. The pivotal trial for pneumonia is the APEX-MP trial. Again, it's a non-inferiority trial. The comparator in this case is meropenem 2 grams Q8, so the optimal dose of meropenem. This is the Probably in the design, this is the best design trial. They include both BAP and HAP, and Klebsiella was the most common pathogen. There is non-inferiority for cefiderocol in front of meropenem in this trial. Again, if you want more information, we have to go to the pathogen-focused trial, that was the credible study. In this case, patients were included if they have an infection by a carbapenem-resistant microorganisms, and the infections included in the trial include UTI, intra-abdominal infections, pneumonia, sepsis, etc. 35% of the isolates in this case are Acinetobacter baumannii, and the comparator was best available therapy, that in fact is a combination of colistin with many other antibiotics, up to 3 antibiotics in the comparator group. In the cefiderocol arm are mostly monotherapy by cefiderocol. There is no difference in terms of clinical cure, but there is a disbalance in mortality in the cefiderocol group that mainly is related basically to Acinetobacter infections, where the mortality is higher for cefiderocol in comparison with BAT in this credible study. Another pivotal study with new antibiotics is the ASPEC-MP trial. Here, the study drug is ceftazidime, and the comparator was meropenem. In this trial, again, it's a non-inferiority trial, but there is some interesting information that there are specific subgroups in this study that include HAP and BAP that make a little bit the difference. The most important is in patients that have BAP and need mechanical ventilation, where it seems that ceftazidime did better than the comparator, and also patients that failed initial therapy and were included in the trial because they failed initial therapy, that also ceftazidime did better than the comparator. Meropenem bavobactam has been studied in 2 pivotal trials. One of them is the site-focused study, which is in urinary tract infections. I'm not going to discuss this study because it's out of the focus of my talk. And the Tango 2 trial is a pathogen-focused study, including patients with UTI, intra-abdominal infections, nosocomial pneumonia, and bacteremia. This is the study I'm going to discuss. The comparator, again, was best available therapy, so a combination of other antibiotics. And the patients that were included in the trial have serious infections by carbapenem-resistant Enterobacterales. So this is the population of microorganisms included in the infections we have in the study. Here, the most predominant ones were Klebsiella and E. coli. The number of patients admitted in the ICU is around 17%, and 40% of the patients are immunodepressed. Pneumonia are 12% of the patients. Most of them have urinary tract infections. The study was stopped because the Data Safety Monitoring Board recommend to stop because they found that there are lower mortality and lower motility in the meropenem bavobactam group. So the study was not completed, but the study shown better clinical cure and better mortality and lower morbidity in the meropenem bavobactam group. So if we try to concentrate this information in guidelines, this is a tough process. I'm going to take the ITSA guidelines to try to condensate this information coming from observational studies and also from these clinical trials. In this case, the recommendation for difficult to treat pseudomonas, according to these guidelines, is to use as a first-line agent ceftazidime or ceftazidime or imipenem relabactam, according with the studies that I have mentioned to you. As an alternative, cefiderocol could be a good alternative. For carbapenem-resistant Enterobacterales, recommendation is to use ceftazidime, meropenem bavobactam, or imipenem relabactam. If you go for KPC specific, the recommendation is the same. For metalos, ceftazidime plus aztreonam or cefiderocol, and for oxa, ceftazidime-avibactam. I am out of time, but just show you our recommendation done by our group that, of course, this is an expert recommendation, and maybe it's not Methodologically, it's not so well done, but includes some of the aspects we would like to discuss. But at the end, it's quite consistent what we have seen in the background and in the guidelines. Similar recommendation for each of the microorganisms that we consider in this publication from last year. So my conclusions are that we are facing this increasing difficult to treat microorganisms, that inappropriate therapy, I think it's a very important problem that is quite consistent in time. We are not able to decrease the percentage of patients that receive inappropriate therapy, especially concern in patients with a critical condition with high mortality. New antibiotics could be helpful in that, but of course having to be used carefully and wisely. Probably the best way is to use it better, because some information is saying that if you use before these antibiotics, you are going to have better results. But of course, this has to be combined with de-escalation and shorter duration of antimicrobial therapy when it's possible. Thank you for the attention.
Thank you so very much for a wonderful presentation. We have time for maybe one question because of time from the audience. If not, I'll ask one brief question for you. I think the summary you've provided and your studies on different agents is great. I'm wondering your thoughts on dosing. Should we be studying more alternate methods of dosing, since we have new agents, but should we be looking at the application of really more interesting dosing strategies, prolonged infusions, et cetera, that have actually taken, in some cases, agents where they are ineffective and made them more effective in these scenarios?
Yes, I think this is a very important point, because lung penetration of many antibiotics is difficult. So we don't have a real way of in clinical task to know if really the antibiotic we are giving have adequate levels in the epithelial lining fluid. We have to stick to levels in blood, but many of us have difficulties to measure levels of antibiotics just for efficacy. So for beta-lactams, most of us have the possibility to measure levels of antibiotics because of toxicity, aminoglycosides, etc., but not for efficacy. Most of our patients have increasing volume of distribution, have increased in renal function during the first, in renal clearance during the first days. So there is a lot of improvement in terms of dosing of antibiotics, especially for the lung. And I think this is an important task for the next years.
Thank you so much. If there are no further questions, we'd like to thank all the speakers for a wonderful session and close the session.
Thank you very much.
Thanks, everyone.